Our presentation is titled Code Status with the Pediatric Patient by Haley, Deanna, Jackie, and Lindsay. So just a brief introduction about what our topic is about. Switching a pediatric patient from treatments to palliative care or switching their code status can be incredibly difficult for the patient, the family, and the healthcare team. According to a practical guide to palliative care, by the age of 7 years old, children typically understand the concepts of death, dying, and end-of-life care. As a nurse, it is important to be present for the family and the patient, as well as provide open and honest communication and active listening. Most families view changing of code status as impending death rather than carrying out the best care for the patient. Be sure to provide adequate education and honest information. So as far as end-of-life care related to the pediatric patient, pediatric patients are often aware when they are being lied to or if the information is being withheld from them. A lot of people think that lying to the patients or younger patients is the best policy, but sometimes being honest with them will actually work out better. Communication is important with pediatric patients since they often know that they are sick and they want to be involved with their care, especially with the older kids. End-of-life care for pediatric patients can be very distressing for both the patient and their family. Care for the patient involves limiting their anxiety, keeping communication open, giving them options to choose from, and allowing them to express their feelings for it. For families, they need honesty, communication, an environment to express thoughts, feelings, and ask questions, and some families may even need a counselor or a chaplain to talk to. At the end of life, pediatric patients need their symptoms managed. As medical professionals, we should not be afraid to give the pediatric patient medications for comfort, such as fentanyl. A lot of people are scared of medications like that and think that they're too strong for pediatric patients. But really, at the end of life, as with any age, comfort is the most important problem that needs to be addressed. Therefore, you should take all measures to make sure that they are comfortable. We need to learn to put our discomforts aside for comfort care of a child so we can provide the best care for our patients. To communicate with younger kids, they may express themselves with art, such as painting, drawing, or music therapy. You have to adjust your ways of communicating depending on their developmental level to get the best results. To explain procedures and treatments, children can be told a story, shown with a toy, and allowed to explore utensils in a safe environment. Sometimes, for example, bringing like a teddy bear and having them put a Band-Aid on the teddy bear or something would help them understand better what's going on. It would make them feel more comfortable with different procedures. Alternative therapies for pain is effective in more effective in younger children than in adults, such as distraction therapy or a sucrose pacifier for an infant. Care of the pediatric patient. It is important to remember children are children. They still want their toys, to go to the playroom, and to have their family with them in a frightening environment. It's so important to remember that care for pediatric patients is different than with adults, and you have to adjust your care plans based on that fact alone. Communication is vital while working with pediatric patients because they can sense dishonesty and lying, which makes care much harder on staff if the child does not trust them. Symptoms should be managed such as pain, respiratory distress, and even psychological distress. The use of drugs such as fentanyl and Versed is widely controversial. However, at the end of life, it offers great pain relief. Therefore, they should be considered as an option, like we mentioned in the previous slide. Alternative therapies are a great way to manage this for children and are much more effective than when alternative therapies are used on adults. This can include distraction therapy, sucrose pacifiers, hydrotherapy, therapeutic play, and guided imagery. Children express themselves best through art, such as coloring, drawing, and painting. As nurses, we must be aware of how to translate that art a child makes to meet their care needs. Sometimes they may have trouble what exactly they're trying to say, like what's hurting, why they don't feel good. So sometimes doing something like coloring or drawing would help them express those feelings, which would help you as a nurse care for them in a better way. There should be a procedure room so treatments are not done in the patient's room. This can deter the child from the room, and it could end up leading to them being scared to go to sleep and just scared to be in the room. And their room should be their safe place. They should have an opportunity to explore their environment and the equipment to minimize distress. Making them comfortable with what's going to be going on is guaranteed to make the procedure go smoother. The use of advanced directives with adolescents. This study involved adolescents between 15 and 18 who were given a questionnaire to discuss their comfort level with and opinions on having a living will at their age. Nurses need to be able to judge and determine when and if teens are comfortable enough discussing the what-if possibilities, fears, and what their personal preferences would be if they were in a state where they could not communicate their wishes. The argument is that teens understand the implications of their choices regarding end-of-life care. They have different needs than adults. On the contrary, teens have not had enough experiences and they are present-day focused. So, continuation of that article. Research questions included in the study were: do teenagers demonstrate decision-making competency? What choices do teenagers make when they are asked to imagine themselves in a coma, and how do their responses compare to those of adults who are presented with a similar scenario? Do teens get distressed when discussing advanced directives, and do they express an interest? And what is the relationship between the adolescent's desire for advanced planning and selected demographic characteristics? 107 teenagers were recruited from 3 high schools, all from different backgrounds in a university-affiliated pediatric hospital. Participants completed the Hopkins Competency Assessment Test, the Advanced Directive Questionnaire, and a form related to demographics. On the HCAT, a score of 4 was evident of competency, the higher the better, and the mean score was 7.5. Between 80 and 90% of teens voted it to be very important for individuals with a life-threatening or chronic illness, risky job, and a major surgery to have an advanced directive. Over 65% of teenagers chose that they would like to have the following if prevented with a debilitating scenario: major surgery, antibiotic administration, simple test, an IV for fluids, and a feeding tube for nourishment. Over 50% of teens demonstrated fear of pain and caused an emotional financial stress on the family. Almost all the teenagers were comfortable or only slightly uncomfortable discussing end-of-life and advanced directives. About 40% of teens thought it was somewhat important for children their age to get an advanced directive, and 47% thought it was very important. The next article is how end-of-life care preferences of pediatric patients with cancer. A unilateral do not attempt resuscitation order is written by a physician without permission or assent from the patient or the patient's surrogate decision maker. Potential justifications for the use of DNAR orders in pediatrics include the belief that attempted resuscitation offers no benefit to the patient or that the burdens would far outweigh the potential benefits. Another consideration is the patient's right to mercy, not to be made to undergo potentially painful interventions. The pediatric population is not deemed allowed to make their own decisions about their care. Unilateral DNAR orders might be motivated in part by the moral distress caregivers sometimes experience when feeling forced by parents to participate in interventions that they believe are useless or cruel. Just to continue with that article, some physicians believe that making these decisions without parental approval could spare parents needless additional emotional pain or a sense of guilt from making such a decision, particularly when imminent death is unavoidable. There are several risks inherent in unilateral DNAR orders, such as overestimating one's ability to procrastinate or giving undue weight to the physician's values over those of parents, particularly with regard to predicted disability and quality of life. The law on the question of unilateral DNAR varies among states, and readers are encouraged to learn the law where they practice. Arguments in favor of and opposed to the use of unilateral DNAR orders are presented. In some settings, particularly when death is imminent regardless of whether resuscitation is attempted, unilateral DNAR orders should be viewed as an ethically permissible approach. The next article talks about challenges to code status discussions for pediatric patients. The study focuses on nurses, physicians, and trainees in the PICU, NICU, cardiac ICU, and oncology units in pediatrics. Physicians were much more comfortable having code status discussions with patients and families than nurses and trainees. 59.2% of attending physicians were comfortable with these conversations. Trainees and physicians believe families are more receptive to code status, whereas nurses don't. Physicians and trainees are not concerned with the timing of code status discussions, whereas nurses believe code status discussions with patients and families occur too late. found that providers have poor knowledge on all the different code options a patient can choose from. It's more than a full code or DNI, DNR. Differences of code status discussions need increased communication since it may cause moral distress, which in turn affects patient care. Challenges include sudden decision-making of parents with a critically ill patient and medical jargon. A challenge for providers is conflicting obligations of disclosure, poor prognosis instead of continuing to provide hope. Different roles of different providers can influence the different opinions. Physicians and nurses are underprepared for code status discussions in both training and bedside care. We came up with a few questions that we thought went along with our presentation. These include, do you think children deserve the right to make their own decisions when it comes to a DNR order for their care? How do you as a nurse feel about having DNR status with a child and their family? And do you think that end-of-life care should be something taught and a type of training each healthcare professional should be required to undergo? Just some final thoughts on our topic and on our presentation. Haley said that personally she felt that if children are clinically competent enough and have a good understanding of death, dying, and end-of-life care, they should be able to have some say in their code status and advance directive decisions, especially children who have been hospitalized by the majority of their life due to severe illness, chronic disease, or congenital anomaly. Deanna said she believes children are aware when they are not told the truth and deserve to be communicated with on their prognosis and care. Children should be able to express their wishes if they're at an acceptable age. Discussing and implementing code status in children is difficult for staff, but it is necessary to provide optimal patient care. Jackie said, I definitely believe children deserve to know what is going on with their health status and care plan. They should be able to have some say in whether or not they want a DNR order so long as they are capable of fully understanding what is going on. Discussing care plans with pediatric patients allows for a better plan of care and better patient satisfaction overall. Lindsay said, in her opinion, she feels like as long as children have reached the developmental level in which they understand the concept of death and its permanence, they should be allowed to make decisions and should be told the truth. If a child is too young to understand, I feel like they should still be included in the decisions as much as possible because it is still their life. And there are references.